Good day. Our topic for this afternoon is how to approach a patient presenting with enlarged lymph nodes. I'm Dr. Crystal Ann Catliburog. Our objectives are to present common etiologies of lymph node enlargement and their basic pathophysiologies. We will also provide emphasis or special focus on findings that warrant emergent and multidisciplinary approach to lymphadenopathy. We will also illustrate the approach to evaluation and management of lymphadenopathy by presenting clinical cases. The lymphatic system is an organ system that consists of a large network of lymphatic vessels, lymph nodes, lymphoid organs, lymphoid tissue, and a clear fluid called lymph. It is responsible for the removal of interstitial fluid from tissues and help maintain fluid balance in the body. It also absorbs and transports fatty acids and fats as chyle from the gastrointestinal tract. Perhaps the most important role of the lymphatic system is its immune function. It is the primary site of cells relating to the adaptive immune system, which includes the T cells and the B cell lymphocytes. The lymph also transports antigen-presenting cells, such as dendritic cells, to the lymph nodes, where an immune response is stimulated. Among the lymphatic system are the lymphoid organs. We have the primary and secondary lymphoid organs. Primary lymphoid organs generate lymphocytes from immature progenitor cells and are represented by the thymus and the bone marrow. Secondary lymphoid organs are sites of lymphocyte activation by antigens and maintain mature, naive lymphocytes and initiate an adaptive immune response. Our secondary lymphoid organs are the spleen and the lymph nodes, and we will focus on lymph nodes and lymphadenopathies. Lymph nodes are an organized collection of lymphoid tissue scattered throughout the body. They are bean-shaped, and they range from 2 to 25 millimeters on their long axis. There are nearly 450 lymph nodes in the human body, and they are grouped according to these regions. The upper limit of lymph node size in adults is generally 10 millimeters. However, there is regional variation. There are several regions in the neck, such as digastric lymph nodes, that may range at 11 to 15 millimeters. In the mediastinum, the paratracheal and subcarinal lymph nodes may be 11 millimeters in size. And in the upper abdomen, the lower para-aortic regional lymph nodes may be 11 millimeters in size. Lymphadenopathy refers to lymph nodes that are abnormal in size, abnormal in consistency, or abnormal in number. It may be classified according to size when the short axis of one or more lymph nodes is greater than 10 millimeters. It may be classified by extent of involvement as localized lymphadenopathy when only one regional lymph node are involved, and generalized lymphadenopathy when two or more regional lymph nodes are involved. It may be classified by localization of the involved lymph node region. The causes of lymphadenopathy may be represented by the acronym Chicago. C stands for cancer. In patients presenting with lymphadenopathy, concern for malignancy increases with age. Cancers are identified in 4% of patients 40 years old and older who present with unexplained lymphadenopathy. One of those malignancies are hematologic malignancies, such as Hodgkin and non-Hodgkin lymphoma. They may also present with B symptoms such as fever, drenching night sweats, and unintentional weight loss. A history of a prior cancer should also prompt an evaluation for possible recurrence or metastatic disease. So this picture is a cut section of a lymph node of a patient with large B-cell lymphoma. An oil immersion field view shows effacement of the normal lymph node architecture by sheets of malignant lymphoid cells. Another cut section of the lymph node from a patient with metastatic breast carcinoma shows infiltration of metastatic cells in the subcapsular sinus. H stands for hypersensitivity syndromes, and this includes serum sickness or type 3 hypersensitivity, drug sensitivity, vaccination-related lymphadenopathies, and graft versus host disease. Medications that can cause lymphadenopathy include the following. I stands for infection, and infection is a common cause of lymphadenopathy. Signs and symptoms, as well as the following pertinent aspects, should be asked from the patient. So this table shows the different viral, bacterial, and fungal and parasitic infections that can cause lymphadenopathies. Another C stands for collagen vascular disease, and this includes systemic lupus erythematosus, rheumatoid arthritis, dermatomyositis, and Sjogren's syndrome. SLE lymphadenopathy may be a presenting feature of SLE, or indicative of an active disease, but it is not a diagnostic criteria. A stands for atypical lymphadenopathy, which may be seen in the following rare systemic diseases. This condition often presents with systemic symptoms such as fever, night sweats, unintentional weight loss, and hepatosplenomegaly. G stands for granulomatous disease. A granuloma is an aggregation of macrophages that forms in response to a chronic inflammation. And granulomatous diseases include sarcoidosis, which is a disease of an unknown cause. It is characterized by non-necrotizing, non-caseating granulomas in multiple organ sites, such as the lungs, the skin, and the lymph nodes. The picture at the left is a granuloma without necrosis in the lymph node of a patient with sarcoidosis. Granulomatous lymphadenopathy may also be associated with mycobacterial infections. And O stand for other causes, and this is what our acronym Chicago stand for. So we will now go to the second part of our discussion, which is the history, physical examination, diagnostics, and red flags of a patient with lymphadenopathy. So let's go first to history. There are certain aspects in the history of the patient that we need to take note because this will help in the diagnostic workup. And one of that will be the age and duration of the lymphadenopathy. So in general, with children, most lymphadenopathies are benign or infectious. And benign lymphadenopathy is characterized by lymphadenopathy that is less than 2 weeks or greater than 12 months without a change in size. However, persistent lymphadenopathy is defined as lymphadenopathy that is more than 4 weeks and may be indicative of a chronic infection, collagen vascular disease, or an underlying malignancy. So aside from the age of the patient and the duration of lymphadenopathy, there are certain exposures that should be thoroughly asked in the patient's history. And that would include environmental, travel-related, animal and insect exposures, medication history, recent immunization, tobacco, alcohol use, and ultraviolet exposure, which increases the risk of malignancy, an occupational history that includes mining, masonry, or metal work may elicit work-related etiologies of lymphadenopathy, such as silicon or beryllium exposure. Asking about sexual history to assess exposure to genital sores or participation in oral intercourse is important, especially for patients with inguinal and cervical lymphadenopathies. And finally, family history may identify familial causes such as Li-Fraumeni syndrome or lipid storage diseases. So the associated symptoms that should be asked during history are symptoms of infection, symptoms of metastatic cancer such as unintentional weight loss, or associated localized symptoms such as dysphagia, hoarseness, pain, cough, or hemoptysis as in lung cancer. B symptoms, especially in hematologic malignancies such as fever, night sweats, and unexplained weight loss, and arthralgias, rashes, myalgias, and fever that suggest an autoimmune disorder. So these are actually considered red flag symptoms, and they should be immediately referred for subspecialty consult. So for physical examination, the most important physical examination in a patient with lymphadenopathy is a focused lymphatic examination of the lymph node and its drainage pattern. So let's go first to the lymph node character. In terms of size, abnormal lymph nodes are generally more than 1 centimeter. However, some inguinal lymph nodes may still be normal at 2 centimeters among healthy individuals. Lymph nodes which is greater than 2 centimeters and are persistent for more than 4 weeks should be evaluated. So that's important, okay, 4 weeks. And lymph nodes that are less than 1 centimeter are rarely of clinical significance. Now, in terms of consistency, firm nodes may denote malignancy, and tender nodes may suggest an inflammation. In terms of mobility, freely movable lymph nodes are considered normal, while a fixed or matted lymph node may be seen among patients with malignancy. In terms of distribution, the distribution of lymphadenopathy may be localized when the enlarged lymph node is seen in only in one region, and generalized when enlarged lymph nodes are seen in 2 or more non-contiguous regions. In terms of location, a palpable supraclavicular, popliteal, or iliac nodes are considered abnormal. And epitrochlear nodes, the nodes that are seen in your elbow, measurement of more than 5 millimeters in diameter is already suggestive of malignancy. A left supraclavicular adenopathy, known as Verkhov's nodes, may suggest a gastrointestinal tract or a thoracic malignancy. So aside from lymph node characteristics, we also have to assess the lymphatic drainage. So this picture denotes the lymph nodes of the head and neck, as well as the regions that they drain and some associated diseases. So we have the preauricular nodes, posterior cervical, supraclavicular nodes, the submandibular nodes, and the anterior cervical nodes. So most of these cervical nodes, actually, when they enlarge, infection is actually a most common cause, and you need to look for bacterial pharyngitis, dental abscesses, infectious mononucleosis, and tuberculosis. However, when you are presented with a supraclavicular lymph node, it is actually already a red flag physical examination because supraclavicular lymphadenopathies is always abnormal. This picture depicts the infraclavicular nodes, the axillary, and the epitrochlear nodes and their drainage patterns. So aside from checking for their drainage patterns, we also have to look at the skin because cat scratches or skin infections can give rise to axillary and epitrochlear lymphadenopathies. We also need to perform breast examination and ask for silicone breast implants as it may give rise to axillary lymphadenopathies. This figure shows the inguinal lymphatic region and the structures that they drain. And again, it's very important to ask the sexual history, especially when presented with inguinal lymphadenopathies. So aside from a focused lymphatic examination and skin examination, we do an abdominal examination and look for splenomegaly. And again, splenomegaly is a red flag physical examination, especially when the patient also have systemic B symptoms. This may be a presenting physical examination of hematologic malignancies such as lymphoma or other myeloproliferative neoplasms. If the history and physical examination are not diagnostic for a specific disorder, these are the initial investigations that we may perform. Now, the optimal diagnostic biopsy, especially when malignancy is suspected, is lymph node excisional biopsy. So risk factors for malignancy include age older than 40 years, a duration of lymphadenopathy greater than 4 to 6 weeks, generalized lymphadenopathy, male sex, a lymph node that does not return to baseline after 8 to 12 weeks, supraclavicular location, systemic signs, and white race. The indications for excisional biopsy includes patient with generalized lymphadenopathy in whom the initial studies are non-diagnostic, patients with localized persistent lymphadenopathy with non-diagnostic initial studies and high risk for malignancy. So these are the patients with more than 4 weeks of localized lymphadenopathy. And patients presenting solely with cervical lymphadenopathy who are at risk for malignancy. So if an excisional biopsy is not feasible, core biopsy may be an option. And core biopsy removes tissue from an enlarged lymph node and allows the pathologist to assess the nodal architecture if an adequate sample is provided. Now, in terms of fine needle aspiration and biopsy or FNAB, it is most useful when searching for recurrence of cancer. However, it has a high false negative rate due to sampling error. Hence, core biopsies have a better diagnostic yield than fine needle aspiration. The American College of Radiology recommends ultrasonography as the initial imaging of choice for cervical lymphadenopathies in children up to 14 years of age, and computed tomography for persons older than 14 years. Full body PET or integrated PET CT may be performed to localize lymph nodes for biopsies for suspected malignancies and may even have a higher diagnostic yield over standard CT scans in many tumor types. So some important histological considerations. We usually avoid inguinal node biopsy as the diagnostic yield at this site is often low. We also avoid empiric therapy with corticosteroids in patients with non-diagnostic workup so as not to confound the result of the lymph node biopsy. And biopsies that are interpreted by the pathologist as an atypical lymphoid hyperplasia should be considered non-diagnostic rather than negative for malignancy. Hence, this patient needs to be carefully followed up, and an additional lymph node biopsy might be strongly considered. So let's now go to our first case. We have a 24-year-old male, a medical clerk, who came due to an enlarging neck mass at the right. So the history started 2 weeks prior to consult when the patient initially complained of rhinorrhea for 5 days and later on developed cough productive of yellowish sputum, fever, and sore throat. He later noted a palpable lymphadenopathy at his right neck. He consulted an ENT specialist 3 days ago and was given coamoxiclav 625 milligrams twice a day. He is currently on day 3 of his medications and sought second opinion in your clinic. He denies any weight loss or night sweats. He has no known disease and is only an occasional social drinker. So the physical examination showed that the patient is alert and awake with low-grade fever. He had hyperemic posterior pharyngeal walls and with a grade 2 enlarged tonsils with exudates. In the neck, there is a 2 by 3 centimeter palpable lymphadenopathy at the anterior cervical lymph node that is soft, tender, movable, and localized at the right anterior cervical region. There were none at the left cervical region. The thyroid gland is soft and moves with deglutition. The chest and the abdomen were unremarkable, including the rest of the lymphatic examination. So how will you manage this patient? Will you do an FNAB? Will you start anti-COX treatment, do excisional biopsy, or finish the antibiotics? So the answer for this case is letter D, finish antibiotics and advise to observe lymphadenopathy. So going back to this case, this was a case of streptococcal pharyngitis with secondary lymphadenopathy. And we are presented with a young patient without other systemic red flag symptoms. And the lymphadenopathy is localized. So this patient actually followed up with resolution of cervical lymphadenopathy after antibiotic treatment. So for our second case, we have a 33-year-old male, an IT manager, who came for an enlarging neck mass at the left. His history started a month prior to consult when he noted a gradually enlarging neck mass at the left cervical area. And he noted weight loss of about 5% of his original weight, but is also on keto diet for a month now. He denies night sweats, fever, or anorexia, sore throat, cough, and colds. He was initially given amoxicillin for 7 days by the company physician. However, he sought consult in your clinic for second opinion. So this patient actually in 2022, he worked up for HIV as part of his clearance prior to his work in Singapore and was actually cleared. He had a 10-pack-year smoking history and had 5 different male partners for the past year and performs oral sex. His father had hypertension. The patient's physical examination showed an alert, awake patient without any oral lesions, but at the neck there is a 4 by 5 centimeter palpable lymphadenopathy at the left anterior cervical region. The lymph node is actually hard, fixed, and non-movable, and localized at the left anterior cervical region. There were none at the right cervical region. The thyroid gland is soft and moves with deglutition. The lungs were clear, and the abdomen is soft and non-tender without any organomegaly, and there were no palpable inguinal lymph nodes. The genital areas were all unremarkable. So, how will you manage this patient? So, this patient is a 33-year-old, very young patient, and however, he has a high-risk sexual behavior and also a smoker. He has this painless cervical lymphadenopathy for 4 weeks now. So, and this warrants further investigation. Hence, we need to do excisional biopsy for this case. So actually, this case was a case of tuberculosis. So for our third case, we have a 43-year-old housewife who came for a chief complaint of dyspnea. She complained of a 3-week history of progressive dyspnea after a flight of stairs and denies weight loss, fever, cough and colds, or night sweats. She consulted a pulmonologist where a chest x-ray was done, which showed a massive pleural effusion. She was advised to go to the emergency room, and at the emergency room, she was alert, awake, and in mild respiratory distress, tachycardic, tachypnic, and a febrile. She had facial edema with distended neck veins. She had prominent venous collaterals in the chest wall, as seen in the representative picture at the right upper portion. She had decreased breath sounds at the right lung field. She was tachycardic. She had no organomegaly. The lymphatic examination showed no peripheral lymphadenopathies, but she had swollen upper extremities. You are the emergency room physician, so what condition is the patient in? So this patient presented with features of dyspnea, facial and upper extremity swelling, and chest wall venous collaterals, which are all signs of superior vena cava syndrome. And superior vena cava syndrome is a condition that leads to obstruction of the superior vena cava, whether by direct invasion of a tumor or an external compression by an adjacent pathologic process, such as the right lung, the lymph node, or any mediastinal structure. So this patient actually had an superior vena cava syndrome secondary to an enlarged anterior mediastinal mass measuring 15 by 10 centimeters in diameter. So this patient was actually handled by a multidisciplinary team. The main attending was actually a pulmonologist who started dexamethasone for the SVC syndrome. She was referred to TCVS for CTT insertion for the massive pleural effusion. The patient underwent CT-guided biopsy of the mediastinal mass by an interventional radiologist and was later on referred to radiation oncology for radiation therapy. And the biopsy of the mediastinal mass was signed out as a diffuse large B-cell lymphoma, hence was referred to hematology for chemotherapy. So we presented the common etiologies of lymphadenopathies and their basic pathophysiologies. We also provided emphasis on red flags that warrant emergent referrals or multidisciplinary approach. We also illustrated the approach to lymphadenopathy by presenting clinical cases. Thank you and good afternoon.